Hi, this is Dr. Casale. We're going to cover a few antibiotics here, ciprofloxacin, levofloxacin, and metronidazole. Before I continue, I would like you to move to the second slide and the third slide here in this slide deck. They both have very important videos that I want you to watch. The first one will be, and I'll flip to it here and then stop the play. Oh, I meant to stop the play. This one has to do with antibiotics versus bacteria, and it's about bacterial resistance to antibiotics. And it's almost a 6 minute, it's 5 minutes and 48 seconds, but it's an important concept for you to understand how it has developed and what we're trying to do to fight it, because important stewardship in antibiotic use is a very big factor today. Second one is this one that I want you to watch and then come back to this recording, is antibiotics and their mechanisms of action. This will help you understand the drugs that we will talk about in this lecture as well as in the part 2 lecture. All right, so I'm going to pass through those, and let's come on here to gram-positive bacteria. And gram-negative bacteria. So this slide should take you back to your microbiology course and maybe even your pathophysiology course, where you can see that we have two different types of bacteria. And the reason I tell you that is because several of our antibiotics, most of them actually, are designed to treat one type or the other. And some of our antibiotics can treat both, but the ones that treat both don't always treat both really, really well. The really good focused antibiotics are the ones that focus on, for instance, just Staph aureus, or just strep pyogenes, or just E. coli, or things like that. But always keep in mind that, you know, we have some good bacteria in our body, and we have bad bacteria in our body. And that means if you look and remember, you can look at your pictures in your book or online at pictures of gram-negative bacteria and how they differ from gram-positive. They are much harder to treat than gram-positive. We really have to have a different focus for the drug, which is why when you have a drug that covers both, it's not always the strongest drug against each. So what are our sites of origin for infections? And this is sort of a review for you. Let's remember that infections can be community associated or healthcare associated. Most come out of the community, and that's like we'll call pneumonia, for instance, community acquired pneumonia. Or there will be hospital acquired pneumonia, which is pneumonia as a result of atelectasis that then leads to development of pneumonia. That's a whole different pneumonia than the pneumonia someone might have picked up just from being in the community. So how do we prevent healthcare-associated infections? Hand washing is the #1 top way that we prevent these infections. And I have a video that I will post with this slide narration that is really an excellent video to help you understand more about how hand washing actually helps to prevent infection, how the actual soap itself works and lifts like viral particles and such. It's really interesting. So I'll list that for you as a fun fact for you to watch. So hand washing is #1 to help prevent healthcare associated infections and really any infections. And then we have antiseptics, and you need to know the difference between antiseptics and disinfectants. So an antiseptic is something that will actually inhibit the growth of a microorganism, but it doesn't kill them. So the organism is still there, but it's not going to be able to reproduce or grow. This is exclusively used on living tissue. So you would not put raw chicken with salmonella on your kitchen counter and then finish up and you clean up. You would not use an antiseptic to clean up because it would leave behind the salmonella. It couldn't multiply, but it's still active and it can still be transmitted to a human and cause infection. In that case, you would want to use a disinfectant that would actually kill the organisms. So in that case, you might be using something like bleach, chlorine, and that is something not used on living objects. So the main difference between the two is that some are used on living tissue and some are used on inanimate objects that are not living tissue. And just to remember, some are bacteriostatic and some are bactericidal. So cidal, think homicidal, for instance, but if you know something's bactericidal, it's actually killing the organisms. And then we have our bacteriostatic. It keeps it static. It's not going to move. It's not going to go through the process of cell division and growth. So what are antibiotics? Well, they're medications used to treat bacterial infections, not viral, but bacterial. And our focus, the antibiotics we're really selecting to focus on for this content here are the self-administered antibiotics, the things people will be doing at home. So when you think about that, they're probably going to be oral or topical. I bet you probably have bacitracin or neomycin in a drawer somewhere at home. That's a topical antibiotic that you can buy over the counter. It's pretty much one of the only antibiotics you can buy over the counter. The others will be prescribed, but then self-administered. We ideally always want to know what is causing the infection before we give an antibiotic for it, because you want to make sure you're actually killing the right or controlling the growth of the right bacteria. And for the most part, clinical presentation and the site of infection help practitioners to suspect what they, it's pretty much a UTI. And UTIs are generally caused by gram-negative bacteria because of the location of the urinary tract system in proximity to the bowel and where the fecal material comes out, which is gram-negative bacteria. So they will typically not culture every single person who appears to have an infection. However, we'll talk a little bit more about that as we go through the learning about antibiotics. Here are some terms that are important for you to understand and operationalize: empiric therapy, definitive therapy, and prophylactic therapy. Empiric therapy is something that we do before we take that culture and before the report has been obtained. So let's say, for instance, you have somebody who's in the hospital and has a high fever or is demonstrating a fever, and we may think that maybe it's pneumonia, or maybe it's the wound that they have, or all these different possibilities. But at this point, the goal is to minimize the potential for sepsis and death from this organism. And so what will be ordered would be broad spectrum therapy. So we're going to give 1 or 2 antibiotics that will cover that. Let's go back, this whole slide, everything on here. It's called broad spectrum. We want it to cover all of these because at the point that the patient is presenting with an infectious process, we don't know which one of these is really causing the problem. But if we don't do something now, the person could succumb to the infection. And if you think back to microbiology, it takes days to grow these cultures. And we may not know for 48 to 72 hours what type of bacteria is causing this infection. So early on, a broad spectrum antibiotic would be used empirically to at least begin the process of fighting the infectious process. Once we know what bacteria is causing the infection, once the microbiology lab is able to identify and isolate what's growing, which takes about 48 to 72 hours, we then can do definitive therapy. So maybe they were on a vancomycin broad spectrum drug, and now we know exactly what's causing their infection. And so now we're going to use a drug that's really specifically tailored towards that type of bacteria. So that's when we move to definitive therapy. And then we have prophylactic therapy. And I want you to think about, a lot of times people who have dental procedures have to take a course of antibiotics before they come in, and they continue them afterwards. And that is generally to prevent what we call endocarditis. It's an infection inside the heart, in the valves. And it happens a lot with oral surgery because of the bacteria in the mouth. You know, it's horrible. We have so much bacteria in our mouth. And during oral surgery, that bacteria is swallowed, or it's knocked loose, or it gets into the bloodstream because, you know, there's bleeding that can occur and it's absorbed into the bloodstream. And it just so happens that the valves of the heart are a great place for bacterial growth. And that can tend to happen as a result of dental procedures like wisdom tooth removal and things like that. So people who are at risk for that, or sometimes that it's just generally a good practice, they will order a course of antibiotics to help reduce the amount of bacteria already in the oral cavity or wherever it is they're going to do the surgery. So here's some more terms that we use in antibiotic therapy: therapeutic response and subtherapeutic response. So therapeutic response is what we're desiring to have. We want to see a decrease in specific signs and symptoms that are associated with infection. We probably won't reculture the site, where the urine, the wounds, the lungs, to look for decreasing growth or anything like that. That's just not what we do for antibiotic and infection measurement. What we look at instead are the symptoms that tell us that there's an infection. Things like fever, white blood cell count. If we are able to see something like a wound, we want to look at redness and inflammation and drainage, and then pain. And a decrease in these things tells us that we're getting a therapeutic response. Now, when these signs and symptoms do not improve, that's considered subtherapeutic or non-therapeutic. We aren't getting a good response at all, and we have to then determine what course needs to change. Perhaps in the hospital, it means we need to change drugs, or if somebody is self-administering their antibiotics and then follows up to see how, perhaps they were self-administering for a urinary tract infection, and they follow up with their provider and say, you know, I'm still having pain on urination. The urine is still cloudy, and I still have a low-grade temperature. We have to ask, did the right drug get prescribed, is the first question. And the second question that has to also be asked is, did the patient actually take their antibiotic as it was ordered, and did they complete their full course of treatment? Because those are things that can confound the therapeutic response. Allergic reactions are a really big problem with antibiotic therapy, probably the biggest adverse effects that can happen. And you need to be vigilant about this and teach, especially for self-administration. We need to always teach patients that should they have any sign of a rash or difficulty breathing, anything that appears to be an allergic reaction, they need to stop taking the antibiotic immediately and notify their provider. Two of the broad classes of antibiotics to which most people have, not most people, but that will cause most of our allergic reactions are the penicillins and our sulfonamides. And a lot of people who are allergic to penicillin are also allergic to sulfonamides and possibly to cephalosporins as well. Here's a long list of antibiotic classes. Again, today we're going to focus on our quinolones and one that's sort of an other, the metronidazole drug. But I just wanted you to see the whole list of classes that we have. So again, remember the actions of antibiotics are either bactericidal or bacteriostatic. Let's talk about our quinolones. Let's get right into our drugs here. They're also, you will also hear them called fluoroquinolones. And we've kind of shortened it to just say quinolones now. They have excellent oral absorption. So knowing that, you know that these are probably going to be very effective in a community practice, a primary care setting for self-administration. They won't need to be given IV. Not that you wouldn't ever see them, because ciprofloxacin actually can be given IV, but just know that their absorption is very, very good. But if somebody is also taking antacids or other things that would change the gastric mucosa, it's going to reduce absorption. So the biggest place that quinolones need to act is in that GI tract so that they can be absorbed. They are effective against gram-negative organisms primarily, and then the fourth generation quinolones have some gram-positive organism effect, which is helpful for somebody who might have a mixed infection of gram-negative and gram-positive. How do they work? Well, they're bactericidal, so they're going to kill bacteria. And they do it by altering the DNA inside the bacteria, which ultimately causes the death of the cell, the bacterial cell. But they don't affect human DNA, only bacterial DNA. And we use them to treat infections caused by Staph aureus, Serratia marsans, and Mycobacterium. So Staph aureus, so if somebody has a staph infection that is not systemic, this is actually a very good drug of choice. So there are indications. Let me go back here. Mechanism of action. I'm curious because the Staph aureus is actually a gram-positive, so it kind of threw me that was on there. But that's our 4th generation quinolone that's used for that. But our normal quinolones up there, ciprofloxacin and levofloxacin, are really going to be used against our gram-negative bacteria, such as Pseudomonas or even Klebsiella and E. coli. So a lot of times they're used in complicated infections, like a urinary tract infection, maybe a respiratory infection, and the CA pneumonia means community-acquired pneumonia. People that develop a joint infection, like maybe after an injury and it's near the joint, osteomyelitis. Now, you may have heard of travelers' diarrhea or Moctezuma's revenge, those types of things. Well, oftentimes ciprofloxacin is used to treat that, and because it is caused by a gram-negative bacteria, and remember their absorption is excellent, so they are going to work well in the GI tract. Some skin infections, and then gonorrhea is another type of sexually transmitted infection that we use the quinolones for. A unique indication for cipro especially is against anthrax. You will have to do bioterrorism training for your licensure, just as you'll have to do jurisprudence as well. And those will be done either right before you take your boards, or you'll have to do it within the first 2 years of being licensed. But one of the things you will learn is that for anthrax, cipro is our drug of choice. And many of you probably don't remember 9/11 and the events of 9/11, but have heard about or read about. Shortly after, there were anthrax threats against the United States in various forms, and that was one of the reasons nurses had to start doing the training for bioterrorism. But I would guarantee you that our government, our federal government, has probably stockpiled ciprofloxacin in the event of a massive anthrax bioterrorism event. So what interactions do these quinolones have? Well, for our oral quinolones, and most of them are, but cipro can also be given IV. For the oral quinolones, I mentioned anything in the GI tract that's going to alter the GI acidity and gastric acid production is going to reduce the effectiveness of a quinolone. So if somebody is taking calcium, magnesium, iron, things like that, and acids, they need to take whatever it is that's going to interact with the quinolone at least an hour before or an hour after taking their quinolone drug. Dairy products also reduce the absorption, so it's best to take it with 8 ounces of water. Don't have any dairy for at least an hour. Enteral tube feedings will interact, again, because of the same thing with the dairy. They're very much a milk protein-based type of feeding. Probenecid is another one because of what it does in the GI tract, nitrofurantoin, and most patients won't be on this at the same time they're on quinolones, but if they are, we need to know it reduces absorption. But the oral anticoagulants is the one I want you to remember. So remember anything affecting the GI tract, and that if they're on warfarin especially, there's going to be an interaction between the quinolones and the warfarin. What types of adverse effects might patients experience who are taking a quinolone, a cipro or levofloxacin? On the central nervous system, headache is usually the biggest one. They'll get a little bit of a headache. The GI symptoms are probably the most significant that you need to kind of alert your patient to. And it makes sense when you think about how well absorbed these are through the GI tract. And so the nausea, the vomiting, nausea, diarrhea, and possible vomiting are usually the biggest things that people encounter that bother them. And we just encourage them to take these medications with a meal, and that's okay. They do not have to take them on a empty stomach. And the next thing that you will want to watch for if you're giving the cipro in the hospital IV with patients who are on telemetry monitoring is what we call a prolonged QT interval. And that's really beyond where we need to go with the scope of our learning here. But you will need to remember that and come back to your book and read about that when you get into probably your med-surg complex care 2 course, or maybe even complex care 1, when you're learning EKG, strip monitoring, and telemetry monitoring, and the effect of drugs on the electrode connectivity of the heart. But you might hear about that QT interval being prolonged as part of this. The other really big thing with our quinolones that I want you to know about is ruptured tendons or tendinitis. So this is a big risk with really levofloxacin has really been implicated. I guess cipro has too, but we need to teach our patients that any tendinitis symptoms need to be reported, and that's upper extremity or lower extremity. While they're taking levofloxacin or ciprofloxacin, if they have any tendinitis symptoms, stop taking the drug and notify the provider immediately. There is a black box warning regarding that. And some people are more at risk than others, and our older adults, of course, is highly at risk for this. So the big things here are your GI problems and your ruptured or tendons or tendinitis with quinolones. So here's our ciprofloxacin. It's a second generation quinolone. And the first generation quinolones really are no longer used because the second generation is so much better. It's oral, it's injectable. It also has ophthalmic, so there's eye drops, and otic for the ears. So it comes in all different types of forms, but if you know it has excellent GI absorption, you can understand that its mucosal absorption is so good that being an eye drop and an ear drop is also very effective. And again, it's effective against like gram-negative bacteria. And the duration of action for cipro is up to 12 hours. So that means it has to be administered more than once a day. So people taking cipro will be taking it maybe twice a day, maybe 3 times a day, depending on what they're using it for. And that, we start to think about, if you watch the video about antibiotic resistance, not completing and not correctly taking antibiotics is part of what leads to antibiotic resistance. So the more somebody has to take it, the more frequently throughout the day, that lends itself to non-adherence or adherence that's not completely the way it should be and can lead to resistance. So we like to find antibiotics that can be given once a day, which really increases the adherence to their therapy. So cipro is at least twice a day, but the next drug, the levofloxacin, is once a day. And when we talk, there it is, there's our levofloxacin. It's also a second generation quinolone, has the same action as cipro against our gram-negative bacteria, but the major difference between the two is that the duration of action for levofloxacin is up to 24 hours. So that allows for our once-a-day dosing, which really increases adherence to therapy. And so you'll see in the community practice and primary practice setting, more often levofloxacin will be ordered over ciprofloxacin simply because of that. So what do you want to teach your patients about quinolones and taking quinolones? And priority teaching, number one, with all antibiotics. So the priority is take it exactly as prescribed. If it says every 8 hours, you must take it every 8 hours. You don't take it. It doesn't mean 3 times a day when you think about it. It really means every 8 hours. Antibiotics must be given on a timed schedule because otherwise we run the risk of antibiotic resistance. And do not skip doses. Take the entire course of treatment. Even if you feel better, do not stop. You have to take the full 10 days or the full 5 days or 14 days, whatever the prescription is for. And when it comes to quinolones, any tendon inflammation needs to be reported immediately. So those are your priority teaching pieces. And then you want to tell them to avoid taking it with the things we talked about before, because it will lead to decreased absorption. And there is a little note here about photosensitivity. Most antibiotics will cause photosensitivity. So anytime someone's on antibiotics, just in general, we tell them they need to be sure they're wearing sunscreen, but to really avoid prolonged exposure to the sun, absolutely no tanning sunbeds, and to reduce their time spent with exposure. That was it for our quinolones. Let's move on to metronidazole, also known as Flagyl. So here's a list of the drugs that come up under miscellaneous agents. And there's our metronidazole, and it is number 3 here on the list. And let's go on into that. So metronidazole is used for anaerobic organisms, and if that's confusing, go back and remember from your microbiology what that is. A lot of times it's used for intra-abdominal infections, but you will mostly see, especially in primary care, for self-administered antibiotics, it's going to be used in gynecologic infections. Things like vaginal yeast infections, trichomonas infections, which is a protozoal infection. And then it does have several drug interactions that are going to be important for you to advise your patient about. So what do we use these? The miscellaneous drug classes cover antibiotics, antifungal, and antiprotozoal. Well, we're talking about our metronidazole, which is going to be our antifungal against candidiasis, for instance. These can be administered PO and IV, and generally these have to be administered every 6 to 12 hours. So you are going to need to talk to your patient about adherence. Widely used for intra-abdominal and gynecological infections, and when we have C. difficile, generally as a result of antibiotic use, metronidazole in its oral form is used to help treat that. Not IV, because it's the oral form and the absorption throughout the GI tract and the entire gut that actually is what helps treat the C. diff. So adverse effects to metronidazole include things of the CNS effects. Now, I haven't had a lot of people tell me, dizziness. I haven't really encountered that a lot as a nurse, but headache and GI discomfort are the 2 really big ones that we usually see with this. And neutropenia and thrombocytopenia that are reversible are typically something we're going to see with the longer duration of treatment, like with C. diff, and generally maybe with the IV treatment. But, if headache and GI discomfort are to be expected with this. And something interesting, fluconazole is another drug very similar to metronidazole, but they there is a fluconazole that can be dosed just once for treatment of a yeast infection for a woman. And its dose is very, very high, and its duration of action is very, very long. So rather than taking something every day for several days, they take 1 dose, and it helps to eradicate their yeast infection, but the side effects can last for several days. So any metronidazole, fluconazole, antifungal, GI discomfort is a big deal. So a significant drug interaction that I need to tell you about with metronidazole is alcohol. And anytime you combine alcohol with this drug, it causes a serious reaction called an anti-use reaction. And they will get violently ill, throwing up and sick as a dog. So we really need to tell people who are taking metronidazole, they must abstain from alcohol for a full 24 hours before they start taking this antibiotic, and then for 72 hours after the completion. And I think it's on this slide. Yes, it is. So there must be complete avoidance of alcohol 24 hours before they start the metronidazole, and at least 36 hours after the last dose of metronidazole. Warfarin, again, is implicated here, and metronidazole can increase the toxicity of warfarin. So if we have an individual who's on anticoagulant therapy with warfarin and we have to administer metronidazole, we want to make sure that they're aware, and this person, we may actually reduce their dose of warfarin. That'll be up to the provider to decide, but just so you know, there is an interaction there. There are several drug interactions with any antifungal drug, so always just check in a drug book, a good drug book, for what other drugs might interact with whatever your patient is taking. So the priority teaching here for metronidazole is the alcohol avoidance. And also, besides alcohol itself, like beer, liquor, wine, they need to check labels of things like cold medications, any preparations that may have alcohol as part of it, like NyQuil is pretty well known for having alcohol in it. And then even mouthwash can contain alcohol. So that is where alcohol can actually hide in things and still cause a nasty reaction. So they need to be taught to look for that. To help decrease the GI upset, they can take this with food. And there is an intravaginal dose that instead of taking an oral dose of medication, it's a suppository, but it's put into the vaginal orifice. And so we usually advise women to do that at bedtime because the suppository melts and then gets absorbed. So if they are standing up and upright throughout the day, gravity works and it tends to pull the medication out of the orifice, or the cavity. So if they take it at bedtime or whenever it is that they sleep, it's better because it gets better absorption. So for any of our antibiotics we've discussed today, you always want to make sure that you assess for drug allergies before we begin therapy. If you are having a patient who's in the hospital, you'll want to look at renal, liver, cardiac function to make sure that everything there is fine or isn't going to be harmed by any of these drugs. And then the culture and sensitivity that might have been sent off for microanalysis from a microbiology lab. But if you're getting these through the primary care clinic, most of the time, allergies is going to be the biggest question that we need to ask. If it's so in general with antibiotic therapy, before we start broad spectrum or anything, we want to get cultures. Now, I'm not talking about when you go to see your doctor and you have a cough or you have bronchitis or something like that. I'm talking about this first bullet point here is generally when we have like a wound that could have a mix of, it could be staph, it could be gram-negative, it could be many different things, or the urine could be a mix, things like that, that we know we're going to have to start with the broad spectrum and then narrow it down. In those cases, you want to culture the source or the suspected source of infection before you give any doses of antibiotic. And that's because if you've already given a dose of antibiotic and then you go to culture something, you may have actually changed already what the actual causative factor is, and it will be not true information. So in the hospital setting, you will see that someone maybe has a suspected infection, they order cultures, and they order antibiotics, and for the nurse to know, you always do your cultures first before you give your antibiotics. You want, of course, priority teaching is to take the antibiotics exactly as prescribed and assess for signs and symptoms of super infection, which happens when we give antibiotics that kill our good flora and our good bacteria. This is typically going to result in like a vaginal yeast infection, or possibly some of the other things that are listed here. Now, as I've gone through here, you hear me say levofloxacin, ciprofloxacin, metronidazole, fluconazole. You can see that many of these drugs have very similar sounding names. When you go to administer these, you really need to check the medication carefully. Make sure that you have the right drug because many of them have very similar spellings and they sound very much alike. So those safety checks are going to be important here. Always assess your drug interactions for classes of drugs. This is something that if you work with antibiotics quite a lot in a certain setting, will become a part of your knowledge base. But if it's a new antibiotic you're not familiar with or you don't give very often, you really do want to look it up and see what kind of drug interactions it has and make sure that you check that against the patient that you're administering the drug to. The most common adverse effects of antibiotics are going to be the GI problems, nausea, vomiting, and diarrhea. Typically, we give them with a meal, and that's helpful. We do know that oral antibiotics are better absorbed if they're taken with at least 6 to 8 ounces of water. So we want to advise our patients to do that. So as the nurse, the final implications for you and your actions are to monitor the therapeutic effects. Do we see resolution of infection? Do we see a change in the symptoms that the person presented with? A return to normal vital signs, for instance, a disappearance of fever, of lethargy, drainage, redness, whatever was whatever led us to suspect an infection in this individual, is it resolving now? And of course, always monitor for adverse effects and reactions. And that's the end of this lecture. And I hope that